So welcome to week 3. The quiz is done. Anybody who wants to review that, let me know. We can go over that together. Sometimes explaining it, me one-on-one with you, can help you remember those informations. Week 3 is you have the NCLEX questions. Be careful doing the NCLEX questions that you're doing them on the area that I'm asking for. Go through the modules and it will tell you those areas to do, okay? Because I do go back and I do look at it. Try to get the best score you can. I will tell you, some students are just so busy, they just want to get something in. At least get your 78 there, okay? As a minimum, because it can, if you're right on that border, can negatively affect you. And I don't want, because your NCLEX questions you rush through, that you're not getting what you need, okay? I mean, many of you get hundreds, which is great, but some of you sometimes just want to get it in. So I'm just going to warn you on that. And again, anybody who wants any help for next week, it is our first exam. I'm going to tell you there are 7 theorist questions. So make sure you go over Freud, you go over Kohlberg, you go over Piaget and Erikson. All of them are there. Maslow, there's 2 or 3 questions on Maslow. So make sure you go over those things and you sort of understand. Now, I think when I did my review this time, because I had a student right before say when you explain it, that the answers, the way you explain it when you're done, you don't just read a definition, you explain what definitions mean, and it does help. So I was really careful making sure I was explaining it well enough so that you can remember it, okay? So any comments about the review, please let me know what I can do more to help you. So let's go ahead and start with our day. So we're going to go into healthcare adaptations. Now, remember, children are different from adults. So we have to remember that. And what's unique and special about adults is you can't just go get a blood pressure cuff and go take it. You've got some double zeros up to extra large adults. What size are you going to use, right? There's a lot of things that are similar and a lot of things that aren't. So informed consent, parents usually will go ahead and sign the consent, okay? Now, it just goes into medical authorization, et cetera, et cetera. There are some cases, like if you're 18 and alert oriented, you can sign your own consent. In fact, the parents can't sign for you. And also, you have to ask that child, your patient, your client, if you can let the parents know what's going on at age 18, okay? And of course, we have emancipated minors, et cetera, et cetera. So there's a lot of different things with consents. Now, one of the things that was seen in errors was that many patients, clients, didn't have on ID bracelets. So today there's a bunch of different times during the day, week, month, that they're doing reviews. They go room to room to room, making sure that all clients have a ID bracelet on. Because, today we're scanning bracelets, scanning, meds, and it's, decreased unbelievably the amount of errors there. So remember, we need to check the ID bracelets. And if they're not correct, bring it back to the charge nurse and she can get whoever it is to send you up a new one. It could be a name, a misspelling, wrong date of birth, whatever it is, make sure it is accurate. Now, in any NCLEX, any HESI, they're going to go over safety. They're going to be going over infection control. These are things that we need to always be aware about. I mean, especially children. Always make sure that the side rails are up when you're not there, or you have your hand on that child, because at 6 months old, a child can roll completely over an infant. So by 6 months, that kid, you have to be very safe, really careful with. I can't tell you how many children that I took care of in the emergency room that was on the changing table, on the bed, on the sofa, and fell onto like, tile floors. And the kid cried and had a bruise and on the head, and parents were concerned. Okay. So it's something that we must, nurses, understand and teach our parents and caregivers. Always identify your patient by their name and their ID bracelet. Years ago, we used to say, oh, this is room 244A, 244B, right? We can't do that anymore. That's where the errors came in because sometimes they switched beds. And I've seen that happen before for whatever reason. And so making sure we're going by the ID bracelet. Now, toddlers who are getting older and love to climb, you see that isolette, that crib in the background? That's the one with a topper, we call it. And it has plastic, and we can pull it all down, pull the side rail up. The kid can't get out because you might see a little 2-year-old trying to climb out, trying to get a toy that's somewhere that they can't reach. And it will happen. They will fall. Okay. Another thing is usually the back of a bed in a hospital. What do you see? You have oxygen, an ambu bag, right? You'll have air, those little things sticking out. Make sure the kids can't get into it. And there's also electrical sockets there. When you are looking at putting a child into any of these type of cribs, etc., make sure you look. Are there any areas where it's broken, it's sharp, that they could be hurt by? Okay. Also, appropriate toys for their age. Okay. We don't just leave medications at bedside, so that shouldn't even be there. But maybe it's we're doing a solution for a dressing change that's on the bedside table. Make sure again that kid can't get to it. All right. You shouldn't be going from room to room changing toys. I know that there's playrooms, usually small ones on every unit. And then, like, for instance, where I worked, there was this big area where the kids could go up in the playroom. And they really were careful with cleaning in between children. So make sure if we are changing toys around that they are cleaned properly, because that's just changing, swapping spit, as I call it, like we do with toddlers. And then always, if you're giving oxygen, be careful, use safety, and let the parents know the safety. Don't try to have any open fires because oxygen supports that flame and it will make that flame a lot bigger. One thing that we have in children is how do we get them from here to there, right? You'll see sometimes kids walking around the hallway, and we have wheelchairs or stretchers pushed to the side in case they have to go for x-ray or an exam or need to be transported somewhere in the hospital. Be careful, kids love to play, and they're going to climb on them. And if they have wheels, they're going to be rolling them, and they are heavy, and they could hurt themselves. Don't ever leave a kid out of their crib somewhere, whether it's on a high chair, a swing. Number one, when you're with them, they should still be strapped in, but they shouldn't be left there unattended, even strapped in, okay? No little kid, again, let's say they're on the floor doing tummy time. You can't leave that kid there by themselves. As I said, we're not going to leave medicines, and we should not ever prop any sort of bottle on these children. It just keeps this, usually there's a little leak, it drips, and they could choke on it, and they could actually do, get aspiration pneumonias, etc. Transporting, positioning, restraining. So we know that where the kid is going depends on how you're going to get there. We know that the older kids can sit in a wheelchair or in, a stretcher and they're fine. Now, sometimes you have younger children that are not really alert. Those kids, actually, you could take the isolette, you could take the cribs, you could take beds if you had to. Sometimes the kids are like these kids that are alert. So let's make it fun. And children's hospitals, they do have these red flyer wagons. But the neat thing about them, they've got harnesses and straps in them to keep them safe, okay? Always, if we're transporting, of course, if it's a crib, side rails up, all right? Always make sure that. And if you're taking a kid to another department, you have to have an ID bracelet. If you don't, they're going to send you back for that ID band. And that is just a lot of extra time that you don't have. So don't do it. And also, you need to document, where did your kid go, at what time, how'd they do, and who brought them there. And this shows a really detailed record of how you took care of that child. So we know that children are definitely different from adults. We know that they respond to medications, treatments, and everything different than adults. So we need to be very alert. So doing an organized assessment. Well, the one thing I'll say is infants, I think, because they're always moving and cooing or crying, it's hard to listen to breast sounds and heart sounds, right? So if I have an infant asleep in mommy's arms, I'm going to listen to heart sounds and breast sounds then, because I know that I can hear it better. Okay. So you want a nice, quiet room. Okay. Non stimulating. And then, just open up the little pieces that you need to look at. Right. And in children, there's something that we call sick appearing, well appearing. And just by looking at a kid, you know if they're sick. If you have a toddler who's just sitting there and not moving, that kid is sick, right? Because toddlers are up and moving around all over the time, all right? You know, blood pressures are usually something the kids all hate. It's a squeeze, and it just feels, like you're trying to hurt them. Don't do it first, because now they're not going to want to touch you hardly at all, right? Younger kids, self-soother, that pacifier, and it does work. It gives them, and they jump on that when they're starting getting stressed out because you're touching them. And of course, you're always talking to them, even infants. And you think infants don't understand you? Well, I've worked in the NICU off and on since 1985. And I'm telling you, even the premature infants, you can soothe them with your voice. And you think that older infants don't understand you. They do. And they get to know. And it's quite amazing how alert they really, really are. I mean, they can't express understanding or anything, but I always felt that they did understand me. Remember, as you're doing anything to a child, infant to, adolescent, if you're talking about what you're doing, that's a teaching moment. And you can do it as you're doing it. So it's not, you're not spending any extra time, are you? Because you have to do that treatment, that whatever, and you're talking about it, what you're doing, why you're doing, how the kid will feel, et cetera, and why you're doing those things, right? And of course, always document it. You didn't document it, you didn't do it. So, observation. How's a kid look? Well, you're sick, right? Growth and development. That's why. Why do you think we do a height and weight every time from infancy till adolescence in a pediatric office? We do a height and weight. What are we looking for? Well, as an infant, we're making sure they're gaining weight, right? Because we know lack of nutrition, they're not getting what they need for their brains. As they get older, it could be a problem with the pituitary gland, or it could be your thyroid gland. There's a lot of different things that can affect height and weight. So it's important that we catch that quick, because with early intervention, we can turn these kids around very quickly and there won't be any delay permanently. Okay. Looking at the kid, the way that they're acting, are they normal? And we know the age of the kid matters. If they're sitting there, they're not around looking, we know something's wrong with that kid. Now, some of the times, children, younger ones, can't tell you where they hurt. But if they're putting their head to the side and banging it, or they're hitting their head, or sticking their hands down their throat, could be an ear problem, or it could be their throat hurts and they're trying to show you. They don't know how, but it hurts. They can tell you. When you have a kid who's in pain, who's laying there rigidly, we know they're just trying to breathe, right? Or Maybe it is breathing, maybe it is pain, but it's something to look at and to, rule out. So listening to those breath sounds very quietly, telling the child what you're going to do, tell them it's going to be cold, I don't want to tickle you, and make it a game. And you could be able to listen to breath sounds, etc. Checking the body for bruises. I mean, look at that picture up there. That's cupping, and we know that Oriental Chinese type believe in cupping because it sucks out the bad poison in the body. But this cupping leaves bruising because it's a round cup thing. Okay. Another thing to look at, and it can't always be, but I mean, if you're in the ER, kids are out running around in the dirt playing and they're filthy sometimes and they broke an arm and they go right to the hospital. But if a kid's coming in for a normal exam that, the parents had time to prepare the child, look, is that kid clean or are they dirty? They greasy? What's their clothes look like? Because remember, as pediatric practitioners, we always must look at the safety of our child. Is that child safe in the environment? And that would be lack of just physical health. So it is neglect. So always have the nurse teaching that child, if they're old enough, and the parents all about how they can keep their child well, what things they can do to prevent them from getting sick, talking immunizations and hand washing, etc. Those really can help. Some parents just don't know. So it does help. When you are doing a history, always find out if there's any other medications that they're on. I mean, many cultures have different things that they do. For instance, my husband is Jamaican. He gets sick and he starts drinking ginger tea and garlic. Now, what could be a problem with ginger tea and garlic? Well, they're both G's. And let's say I had a bleeding problem, they cause the blood to be thinner. So it could end up a big problem. So just as simple as that, we need to know complementary, alternative, and even, of course, over the counter. But you can see how just ginger garlic tea could be a big deal. Always look at how is the kid eating? How are they overall? Are they healthy? Have they been sick recently? How do they sleep? Do they toilet by themselves? Or do they have, soiling episodes? What do they like to play? And then needing to know what sort of things they might do that's on that just particular that child. Sometimes they go like this with their fingers. Now, I didn't know what that meant. And then I found out that means I want more, or give me milk. I mean, I didn't know those things, but this is something parents need to tell you so you as a nurse can take care of that kid. So physical survey head to toe ain't going to happen head to toe. It's going to happen when you can get to that place in children. Older kids, yes, head to toe. Younger kids, it's not going to be because they're not going to sit there that long. So what would be part of the physical survey? Temp, height, weight, blood pressure, hydration, capillary refill is how you do that a lot of times, and just mucous membranes, heart sounds, lung sounds, bowel sounds, and then looking at the body. Are there any bruising, rashes, insect bites, etc., etc.? Now, pulses and respirations. They say apical pulses are advised for children younger than 5 years old. It's more accurate. After that, you can go to radial pulses. You're adults, we do radial all the time, unless we're going to give it to digoxin, right? And then we have to do an apical pulse on them. When you're listening to the lungs in children, many times you're going to hear those lungs junky. Be careful. Sometimes it's all just upper airway secretions. So know how you are going to listen to it, knowing that it could be upper airway. Maybe they need to blow their nose before you listen to their lungs, okay? Remember, if you hear a child's, their heart rate is faster than normal, is it because they're anxious, stressed, or is it a fever, or is it dehydration? Okay, all of those things. Or it could be they're in respiratory distress. Then you would see increased pulse, increased respiratory rate. So there's reasons why you'll see certain things. Why? Why are they like that? And then take the temperature, right? And then ask the parent, how many times diapers did you change today? Were they heavy? Were they light with urine? Okay. These things are important. And as I said, infants, they're quiet. Listen to the heart and the lungs first. Now, blood pressures. You see that little one on the bottom? You put it on your finger and take your own blood pressure that way. So that's how small they can be. And yes, we do cuff pressures on the very, very, very small infants that are premature. The width of the cuff should be 2/3 of the upper arm. And remember, those electronic ones have saved a lot of listening today. And older kids, I let them push the button and it makes it more fun. And then we sort of say, okay, what's that last number going to be? Let's make a bet. And they're not going to be worried about it squeezing. I do lower extremities on those toddler preschoolers. It seems to work better than the arm. I know I don't like my arm pinched with a blood pressure cuff. It always hurts. It pinches. I got a pudgy upper arm. So I was thinking the kids were the same, and they do really well that way. And you do get an accurate blood pressure. So blood pressure cuff can be taken, but remember, if they're kicking, screaming, it's not going to be accurate. So fever. Fever is when the body is reacting to something that got in there, a virus or a bacteria. So remember, there's all about what happens with it, okay? What we need to know about fevers is what happens. Well, your body is getting hot, it's reacting to something, and we'll know that we're going to see increased respiratory rate and an increased heart rate. And then we touch the kid and we're going to figure out what's going on. Now, hyperthermia is sometimes a kid is out in the heat. I mean, I live in South Florida. Could be very real here. Gets hot or it gets in the car, stuck in the car, and they get hot. Antipyretics will not work on this person. You need to cool them down with a cooling blanket. It's because of the mechanism of the prostaglandins are in the normal fevers. It's not with hyperthermia, which is due to too much heat. So antipyretics don't work, but we can, and they do have cooling blankets. All different sort of ways to do temperatures. I mean, I remember when the ear one came out and we were like, I was so excited, but initially it wasn't that accurate. Today, all of these thermometers work really well. In fact, I always tell my parents, go to the dollar store and get one there, the electronic ones, beep, and actually they work just as well as the $10 ones from inside the drugstore. So oral, axillary, temporal, tympanic. Remember pain. Pain is something that now must be done on every shift when you are taking care of adults or even children. So children can't always tell you the way they feel. They could be nonverbal, like nonverbal cerebral palsy, or it could be nonverbal because they're an infant. So they say under the age of 3, you're going to use a flack scale. And what it is you look at the face and you figure out, is it a 0, 1, or 2? And then you write that number after it. And then you go to the legs. Are they kicking, going nuts? Well, that's a 2. Activity, are they laying quiet and they move and it's not a problem? It's a 0. But if they're arched and not feeling good, again, a 2. And you add them up and then you'll get the pain scale up to 10, right? Because you're adding up numbers. And we know a 10 is a 10, whether it's numeric or a flack scale. Now, at preschool, age 3, that's when you start using the FACES scale. And it's so cute to watch a little 3 or 4-year-old point at the little faces, and they will tell you exactly how they feel. And what's neat about children is they don't lie and they don't over exaggerate it. They're telling you how they really feel. So again, flack is under the age of 3 or even an 18-year-old nonverbal cerebral palsy child. They just don't talk. They can't tell you. And then faces is that from 3 years old till 8, and then you can use the normal numeric like we do in adults. Weight, again, what do we want to what? Why are we weighing them all the time? Well, number one, we're trying to figure out, are they gaining weight they should? Are they too much, too little? Because interventions need to be taken place. Too much, maybe they're feeding them juice in between or something, or overfeeding them. And then too little, remember, they need that nutrition for their brains and for growth. And of course, weights are always done because we give medications, milligrams, micrograms, mmQs per kilogram. And that's just the way we give medicines, and we do it safely. We can't just give 2 Tylenols like we do in adults. Heights, again, we're looking at how tall they are. I do a lot of the heights for the infants, just sitting there on the stretcher in the ER. You put your hand out, the parents hold them, help you, push out the leg and put a little line, and then I measure it with a tape measure. And that's as easy as I do there. And then the older kids, some of them you have to be careful with. They don't want to go back, especially if there's like a big wood block on that thing that comes down on their head. So you need to tell them they're not going to get hit. It's not going to hurt. And you need to let them touch it. And you need to let them put it down until it touches their head. And then they're not going to have fear, because a lot of them think you're going to hurt them because they fear caregivers, because we give those shots, don't we? We give shots. Head circumference is done on all infants and toddlers. And why? Well, we know the anterior fontanelle doesn't close till up to 18 months old, usually about 15 months. Well, what if it doesn't close? Or what if it closes too early? Both of those have problems. So that's why we do it all the time. And it's just up around the forehead. Usually it's the first thing we do with assessment in the morning. And then we write the number down, look at what happened yesterday, and say, oh, it's up a centimeter. Well, it could be hydrocephalus, right? Water on the brain. So very important that we look at these things. Collecting specimens, make sure you look at the order, you get the lab requisitions, you get it, and make sure you label it. Can't tell you how many times labs have been sent to the laboratory, the blood, with no labels on it. You know, they're going to throw it out and tell you to do it again. And on an infant, you're going to have a very angry mother, because you have to do it again because you didn't label it. Really? I want another nurse. Where's the charge nurse? And now you have problems. So make sure. I mean, I understand. I wouldn't want to stick an infant twice, right? And then make sure it goes in the proper bag. Usually they're biohazard bags. And again, document. There's all sorts of specimens we do. We can do urines in many different ways. We do straight casts, we do bags, we do clean catch. Stools, many times we get the specimen, or sometimes it's just a swab around the anal orifice there. Blood, many times it could just be a pinch, but sometimes we're going to have to do just the venipuncture. Cerebral spinal fluids, ruling out meningitis. And then if they have some sort of wound, we're going to see what is the bacteria that's creating that wound. Sometimes it's body fluids. Always make sure you do it correctly. You have the requisition, it's labeled, it's put in the proper container, and make sure it gets sent to the lab. Now, one of the things that as nurses, you can't get this urine on this kid. You can't squeeze it out of the diaper for a specimen going to the lab. Now, I have actually taken it from the diaper, put it in a syringe, just to, at bedside, look for glucose, because that is a common thing that you do in the newborn intensive care unit, but never to the laboratory, okay? It's just a little bedside thing that has, I know I've done. So a nurse is admitting a 3-year-old boy with a very high temperature who is restless and crying. What safety measures should the nurse institute on admission of this child? What are things you would think about? They're being admitted to the hospital. What do you need to be safe? Anybody? The toddler. just turning
The
into preschool.
the ID bracelets.
Absolutely. That's the number one thing. Okay. What else? What about their bed? You know, we put them in a crib. Do they need the bubble on top? Are they old enough to stay in bed? Better safe than sorry, isn't it? Have it somewhere in the crib pulled up. And again, keeping all that stuff that they can't get into those things. Also, what about toys they bring in? Making sure that they're appropriate. They won't swallow them. Older than 3-year-old, right? So all of these things that you would do normally, think about it when you're getting a child put in, because now they're in your care. You're responsible. Remember, children are just like the elderly. You know, it's the same thing. They respond to medications differently. You know, it's because in the older adults, it's because their body systems are worn down. In infants and younger children, they're just immature. They're not working as well. It's almost the same concept. So remember, the way you give medicines to children, they're going to respond to them in different ways. You might need less medicine than more drugs. And a lot of times with some of these medicines, we're going to be monitoring blood levels to keep them safe. So we save, and for instance, the aminoglycosides like vancomycin, CIN. That's where we do peak and troughs to make sure we're not killing their eyesight or their hearing or their kidneys. So all of these things could be affected. We know younger kids, their GI tract is not as mature. It's going to run through. Their gastric juices aren't as much. So we got to remember that. Maybe we need a bigger dose because it goes out there quicker. Remember topical medications. They do get absorbed. Let me give you an example. It was an 8-year-old boy came in. He had a rash from head to toe, and he had been on, I think it was amoxicillin. And the father, because he was itching, took Benadryl and slathered the kid head to toe. And he gave him Benadryl by mouth. This kid came in a catatonic state. Couldn't move, couldn't talk, just, and I'm going, this is an overdose of medicine. So my point here is littler is better than too much on topical medicine. Just like steroid medicines you put on, remember, it does get absorbed. So be very careful. And remember, parenteral, once it's in, it is in. So you have to be very careful. Anything IM, IV. We know that most medicines are metabolized in the liver, and then, you know, it goes through and then we excrete in the kidney. Remember, everything is immature. So you might have lower levels than you want. Or if it doesn't excrete, it stays in there longer, and then it could build up and compound and be too much. So these are things we have to think about it. Again, that's the excretion, and why. It's just, again, it's in there longer, get another dose. That means you double dosed. And then you could put this kid into too much medication. With children, you might see a reaction on the first dose, or it might be the last dose of the antibiotic, or anywhere in between. And it could be redness, could be rash, could be respiratory, could go anaphylactic. Any of these things could happen there. So as nurses, we're going to make sure that we are documenting first time given amoxicillin, no rashes seen. Next dose to be given, you know, inspected child, no rashes, no respiratory distress. I mean, these are things that you should be looking for and be aware of. Parentation, well, who takes care of the kid at home? You know, older kids can be involved in this, absolutely, but parents need to be a part of it. And as I said, when you are doing things for the child, you're talking, you're telling them, you're teaching them, and it does it once. And then on discharge, make sure they have written instructions and know exactly what to do and when. You know, we prefer to give oral medications. Kids don't like what? Well, they don't like the nose, the ears, the eyes, just it scares them. Rectally, they don't want you touching down there because it's uncomfortable. And they don't want a needle, do they? They don't want IM, sub-Q, IV. They don't want to put IV. Remember, they're a little nervous about them. Now, giving medications depends on who the child is, what do they have, and what medications are required. Now, that picture up there is a Broviac. It is a long-term use. Many times we send children home on that who have long-term antibiotics, or maybe they have a problem with digestion and they need hyperalimentation, lipids at home. These are things that we would use. And it saves them from being stuck every single time. I mean, they're getting away from Broviacs and more central. They're going more into those PICC lines, which is a peripherally inserted central catheter. Usually goes through the arm somewhere, and it goes up, and it's tiny little tube that goes into the heart, and it's like a central catheter. So again, just be careful. It is a place where you can give an infection to the children. So really good care when you're doing that. Knowing how much medicine you can give a kid and where you're going to put it, right? Well, IM in a child's going to be in the vastus lataris, the thigh, right? And the infants, 0.5 ml, toddlers can go up to 1 ml. Now, as they get older, you can give 1 ml in the deltoid, depending on the medicine. You're not going to put that thick white bicillin antibiotic in an arm because it burns, or even steroids, Solumedrol, Solucortef, prednisone, that sort of thing. That we're not going to give in an IM because it hurts and it burns. So we sort of have to learn that as we go. That one we would do in the vastus lataris. IV medications, as I said, it's direct. It goes in, it gets absorbed. So we need to watch it. Now, one of the problems with anything IV is that, of course, after time, the IV is going to come out, stop working. And many hospitals have rules as you can have it for 72 hours and you have to change the site. I've seen some horrible infiltrations, and that I've seen skin surgeries and flaps and plastics that have to be done because of the amount of damage. So that's why we need to check them every hour and make sure it's not swollen or reddened or leaking. And if it is, stop the fluids immediately. Watching intake and output's important, and all we're going to do is document it as it goes. Parental fluids, remember, when you're giving IV fluids to a child, you need to figure out what is going to be the best for which age group. That's the developmental level. Now, infants, younger children, many of them suck a thumb or a finger. You wouldn't use that hand for your IV, would you? That's going to create stress on the child. You use the other hand, okay? You're going to be trying to put it in a place where they can't pick it and get to it most of the time, and putting an arm board on. Now, don't over tape it, over cover it up, because again, we need to look at it and we need to monitor it closely for infiltration. Medication safety, we've been through this in your other courses. Patient, drug, dose time, route, documentation, make sure all the sixes are done. And the first thing is checking their ID bracelet, right? Now, in your calculate with confidence, there was BSAs and BMIs, and you're like, why do we do that? Well, we don't necessarily do that in routine hospitals today. We usually do the milligrams per kilograms, micrograms per kilogram, but this is actually the most accurate way to do it. And that's why we have you do it and show you the way it's done. So again, with IVs, make sure you know where you're putting it. That little thing, that plastic thing, they call those little houses, believe it or not, and they work really good. And sometimes you see there's elbow restraints on that child, so they can't get to it, right? So there's things that we can do to help that child not pick at it and prevent it from being dislodged. Also, again, mom and dad, whoever's caregiving, who are there with that child, they need to know how to pick up that child, how to hold that child, how to change a diaper if they want safely without dislodging an IV. So we're lucky today because pharmacists are really involved in the care of the children and adults about the interactions of drugs. So we know that, for instance, one of the things I can remember clearly is I was going to give an antibiotic, ceftriaxone or Rocephin, very common medicine given it's a broad spectrum antibiotic. Now, when you go to get that, when I was in the ER, I had to pull it out of a Pyxis. When I pulled it out, it says patient is not on Ringer's lactate because it's that contraindication. So there are things mixed which could create a lot of problems. So it's one of the things, read the labels, see what they're telling you. When you're in doubt, call the pharmacist, okay? I mean, one of the things that the pharmacist is not going to help you with is breakfast, an egg, and not giving iron right after eating the egg because it stops it from working. So nutrition, digestion, elimination. Many younger kids are gavage fed, whether it's an NGT, nose, or OGT through the mouth. Some of them we do it. And it puts that in there and gives them their nutrition because they're too young, some of them, they can't suck, swallow, and breathe, or maybe they have impaired sucking due to some sort of condition. So it is a good thing that we do it, and we do it by gravity. Gastrostomy tubes, there's many different types. This one up top basically shows you the one you could take off the end and just a little buttons left. And that's actually good for your kids because you know that thing swinging around and they can actually pull out their GT if it gets caught on something. So there's a hole made in the stomach's brought up to the abdominal wall, and they put it in there. Now, the one on the bottom is the one that it hangs out. There's no way to disconnect it. We would like them all to be able to be the button and take the thing off. But usually it's insurance, believe it or not, that don't let you do some things. Now, we give enemas to children, not routinely. You should never give routine enemas to any child. Now, when would you give it? Well, I'm going to give you a little story about my grandson who was 3 years old. He was 3 years old. He was sick with the flu and he was being potty trained. And all of a sudden, he stopped urinating and he was drinking, but really not eating. And his belly was getting large. And I'm like, it's been 24 hours. We went to the ER. Well, what had happened? He was constipated and his abdomen was full of stool. So they gave him an enema and I said, give me an extra large diaper. He wore a size 3. I said, give me a 6. And they gave him the enema and it all came out. That be the only time in those cases. There are children who the only thing you can control is their bowels that will hold it to get attention. Again, those children, to get them moving, they might give them also a Fleet's enema. And there are pediatric ones, okay? Respirations. You know, one of the big things in nursing is breathing and a lot of problems with breathing. So remember children who are restless and you can't get them comfortable. One of the things to check is your O2 saturations. It could be it's a respiratory lack of oxygen to the brain, okay? Or you start seeing them elevated heart rate, elevated respiratory rate, and then you start seeing retractions, in young kids, nasal flaring on the infants, and then of course their color is going to change. So this is something that really needs to be investigated. When do you suction a child? Well, if the kid can't blow their nose, or if they're so full that they need help, or they're just so tired from just breathing, you would take and suction them. Remember, you can't keep it down there longer than 10 seconds, okay? And down once and out. And it should clear out the respirations. Again, remember I told you that noisy up here can create breath sounds that are not what they really are. You can have clear breath sounds and they sound like they're full of rhonchi. There are some things with respirations you have to be careful about. One is called a tracheal esophageal fistula, and it's exactly a tube from the trachea to the esophagus. So if you eat or drink, it goes down the esophagus, across that fistula, that tube, and directly into the lungs. Now you have aspiration pneumonia. So you wouldn't really be suctioning then. It would be, or you just did little mouth suctioning be done. There could be narrowing, there could be a problem with the trachea, et cetera, et cetera. Or, if you have a trach or an endotracheal tube that it's all blocked off, sometimes you have to take that out and just manually ambu that child. So remember, when you're talking about airway obstruction, you're going to do the abdominal thrusts and chest pats, right? And hopefully this is going to help get that out of them in the younger kids. Preoperative, postoperative. So preoperative, kids don't really know what's going on, right? So remember, they do need prepared on the level of their developmental, where they are. Don't try to over explain to them. Use a doll, use a teddy bear, something. Show them what's happening. Let the child ask any questions. Even 2 and 3-year-olds will ask you questions. Just make sure you're answering on a level that they understand. Now, one of the things that we know is adults, you're going to be going to OR the next day, you're NPO after midnight, right? We don't do that in children, especially infants. They do not want you NPO longer than 4 to 6 hours. Their blood sugars will drop drastically. So sometimes even breast milk will give up to 2 hours prior to going to surgery, okay? And this is the time where you would give them that oral self-soothing, you'd give them a pacifier, and that does help. Now, post-operatively, what is your job as a nurse? Well, most children will remember it being painful. They're going to remember laying there and being uncomfortable, and nobody wants to come, right? Well, when we have a child, we're going to make sure that they're medicated for pain, that they're positioned, hot packs, cold packs, pillows on their knees, whatever you have to do, try to help them. And another thing that we do with pain and post-op, distract them. It could be TV, could be iPad, it could be, something that they can do that doesn't hurt them with moving. Distract them somehow. So an infant who still wears a diaper was admitted to the pediatric unit with diarrhea that has lasted for several days. The physician has ordered the application of hydrocortisone cream to the infant's head and buttocks. Should the nurse be concerned about this order, and why? What did I tell you about creams? This is a steroid cream, and you have a red and opened area of skin. What do you think I'm concerned about here?
Well, if the skin is open, it might burn.
It could burn. Yep.
And then it's just going to make a gooey mess.
It's
Why would
also
you
going to
use cream?
be absorbed into the body
Yeah,
faster, and more is going to be absorbed. And now you're going to have steroid all in
right.
that child too much. So very good. Yes, it burned, and you don't want to hurt anybody.
Mm-hmm.
Number two, it's all about that medicine going into that body, and that
Mm-hmm.
could create a lot of problems too. Thank you. Very good. So, everybody ready for a Kahoot? Yes? Well, here we go. Any questions? All right. All right, let's get going. Week 3, Chapter 22. After instilling nose drops, the nurse will keep the infant in the head down position for at least how long? That means you want the medicine to go back and get in the nose. It needs to get into all those little capillaries in the nose so it's absorbed and it will do what it's supposed to do. How long do you have to keep them like that so they don't get up and it drip right out? It's about 30 seconds to a minute, believe it or not. They really want to stay there. So if it's a younger kid, have it in the parent's arm and they can hold them, like they're hugging them, right? And then you can make into swinging them, make it fun, and they don't even know the 30 seconds have gone by. When planning care for a toddler, what behaviors do we need to consider to promote security? What do we know about toddlers? Toddlers, me, mine, all that negativism that they have, right? How do we get security? Well, toddlers like routine. It's called ritualism. They like breakfast at a time, certain foods, nap time, bedtime, bath time, reading a book time, playtime. They like it to be the same. They do not do well with that change in behavior. They are into parallel play. They don't play with other kids. They play next to them with their own toys. And they're like the me, mine. And that's just part of who they are at this time. So, toddlers, ritualism, very, very important. Same thing all the time. And as nurses, it becomes a struggle if they're admitted, right? So, how do we keep that going? At least we can give part of it, hopefully. According to Maslow, what level of hierarchy of needs correlate with measuring vital signs and O2 saturations? So we know we go from the bottom all the way up to the top of steam. Which one is it? And it's physiologic needs. That means this is something that you can measure. This is something that you could see that maintains their body, physiologic. If it was the top of the pyramid, esteem, that would be like a school age child who plays soccer and does it well. That is their industry, but it's also esteem according to Maslow. Okay. A child explains that the nurse said he got sick because he went swimming in the rain, according to Piaget. It's concrete operational. This is like a school age child that they're trying to figure out why he got sick. The earlier ages, pre-operational and sensoromotor, is God made me sick because I kicked my sister yesterday. But as you get older, according to him, concrete is, well, probably because I was swimming and it was raining. That's why I'm sick. So they're starting to use concrete reasons why. Now, your adolescents are formal. They're going to even figure out more stuff. Why? They're going to go on and on and on about it. Why they're sick. As I said, adolescents will talk their way out of a paper bag, figure things out, and try to get things the way they want it to be done. For instance, what if a mom says, "You're not going out Saturday night because you didn't do well on your exam, and I told you to clean your room and you didn't." So, what does an adolescent do? They want to go out Saturday night with their friends. So, they do the dishes, put their clothes away, they take out the garbage, get an A on an exam, and they're nice to their brother and sister. And mom says, "You've been good all week. Okay, you can go." They figure out 100 different ways to make mom change their mind. That's formal. School age is what they know and see. That's concrete information. Formal is they can figure it out. They don't have to see it. Gentamicin eardrops are prescribed for a 4-year-old child. How would the nurse position the auricle? Up, back, down, over, what? It's up and back, okay? So knowing positions of the drops. Going back to pharmacology. What is the best pulse location for the nurse to use when assessing the pulse rate on a 12-month-old infant? I could say up to the age of 5, right? So it's apical. We do not do it anywhere else earlier than that. The book says we're going to do apical pulse on all children up to the age of 5. Then we can use whichever other one we want, radial like we do with your adults. A 4-year-old child asks tearfully if the IM injection will hurt. What is the nurse's most effective response? You need to be honest with children. Children want to know, and they don't want you to lie to them. So if you tell them it will be just a little bit, we'll do everything we can to try to hurt less. They would prefer that to say, "We'll hold you down so you don't move. It'll be over quick." I mean, that is not what they want to hear. Be honest with children, or they're never going to believe anything else you say. What antibiotic is known to cause discoloration of the teeth in young children? Back in the 50s, 60s, it was one of the only antibiotics out there and was used all the time. We don't use it that much anymore. And it's tetracycline. And what it does is the teeth turn gray and you can't like whiten them up. It's not going to happen. It has something to do with the enamel. It looks like dull gray. I worked with a nurse who had the gray teeth, and she had tetracycline when I first became a nurse. A parent tells the nurse, I'm not sure how to give this medicine to my infant. How would the nurse teach this parent? Giving medications to all age children to some parents is so hard. And nurses really need to teach these parents tricks because they need to take every dose, right? There's things that can happen when they don't take all the doses of antibiotic. So you're not going to squirt it in the back of their mouth because they're going to vomit, okay? And they're not going to use a cup, you're going to do a little bit of syringe on the side of the mouth, slowly putting it in. Sometimes you have to hold the cheeks a little bit so they don't dribble it out, but take your time with it. And these kids will take it well. Infants don't really worry about the taste of it. They don't have that great taste buds yet. So even if the medicine tastes horrible, they think it's great. So slow and easy. When should a child begin to be able to feed themselves using a spoon or a fork? So it's usually by 2 years old. Now, let me tell you, they might be using the spoon upside down and backwards, but they're attempting the motion, all right? They don't do it completely correct till later on, and that's okay. We're just trying to give them some autonomy. Remember, a 2-year-old is a toddler. What do we know about toddlers? Mine, me do. I want to do mine, right? So letting them do it, even if it goes all over the place, it's something that has to be done. It's part of their learning. Should parents be concerned about how much fat they include in their young child's diet? Do we need fat in their diet? So it is very important. Even if a child is overweight, weighs too much, for instance, if they're born at 7 pounds, by 1 year, they should triple and be at 21 pounds. Well, what if they're 26 pounds? Would you cut out fat to decrease calories? Absolutely not. Fat is good for the central nervous system and it helps with growth and development. So you will not decrease the fat till age 2, and maybe not even then. So fat is something children need in their diet. What type of play are toddlers known to do? I was just discussing that one. So associative play is children playing together, but they're not making or doing anything. There's not a goal. Cooperative play is 2 or more children playing together, but there's a goal. They might build a house, they might build a sandcastle. It might be a board game and somebody wins. Parallel play, absolutely all about toddlers. Playing next to each other with their own toys, not mixing, but they're playing with each other's. Because, right, they don't share. Me, mine. So next to each other. Takia, you're doing well. Which restraint is most appropriate for the insertion of an IV line in a scalp of an infant? One of the things that's hard for parents to see is an IV in the scalp of a child. And we don't like to do them unless there's really nothing left. But if we're trying to put in a scalp vein, we want that child to be as comfortable and quiet and not moving as possible. So we don't want their legs moving. We don't want them reaching up. So it is that mummy restraint. Okay. Elbow restraint, their feet still can come up. And they're so flexible that that could also disturb. So a mummy is actually the best of all. I've started many a scalp vein, and they're actually pretty easy to get in. The concern with scalp veins is there's a lot of arteries up there too. So sometimes you get it in and you find out it's an artery. So it can happen. How often should a child who has continuous IV infusion be assessed? And I'll say, does it matter a child, adult, any client, any patient has an IV? How often should you assess them? And we know with children, it's most important because 10 mLs on a little 3-pound baby is a lot for them. And now their foot is blown up. So every hour it must be done in pediatrics, okay? Because of the damage it can cause. What type of method is most accurate way of determining the correct dose for children? I'm not saying we use it. And we know it's the BSA. Now, what do we really use? In reality, in the hospitals, it's milligrams per kilogram, micrograms per kilogram. It's all based upon weight. Now, yes, the most accurate is your BSA. According to Kohlberg's conventional morality, school-age children believe what? So school-age children don't want to do bad because they don't want to be punished. They follow the rules because it's the right thing to do. They are pleasers. School-age children are pleasers. They want to do the right thing, and they're doing the right thing because they do not want to be punished, okay? What developmental level of Freud are school-age children developing to form friendships? Well, look at the words and which one could it be, right? Well, orality is all about infants and searching the world, exploring it through their mouths, right? Anally has to do with potty training, and it has to do with, bowel training. And phallic is when we get to those preschoolers, it's all about knowing that we're different, boys and girls like their dads, and boys like their moms. Latency is all about same sex peers and friendships. So that is why that's the answer. Adolescents are all about body image. Eric describes this as what? They're always worried about what do they look like. Are they too short, too tall, too fat, too skinny? Hair's too long, too short, too curly, the color of their eyes. I mean, they worry about all those things. And it's because they're worried about their identity, of course, there's that role confusion. Remember, adolescents are those ones that they've gone from childhood, now they're becoming adults, they're confused, they're frustrated time of life. What do I want to be when I grow up? Sexually, who do I like? Do I like boys? Do I like girls? Do I like the way I look? What group am I going to fit in with? Is it the band group, the sports group, the smart kids? Who is it? So they're searching. Very frustrating time of life. And body image is huge in adolescence. What is the final stage of Piaget's developmental theory where the adolescents increase moral reasoning? Told you about this one fighting their way out of paper bags. This is where they have their own critical thinking skills. They can think things up. They don't have to see it and try to relate it. They're in formal operation. They formally can figure things out. Concrete is sitting there. It's set in cement. They have to see it and then they relate it. Does that help you understand that one better? A mother is concerned her child has developed a fear after an immunization. What education should the nurse provide? So, fever after immunization, what's happening? Well, remember, they're introducing something into the body, and the body is reacting to it so that it can make protection, the antigens and antibodies that will protect them from it. It's absolutely normal. Also, following immunizations, you might see it red and hot and swollen and hard, and it's uncomfortable. What they say is to take the knees and the legs, put them on their back and pedal them. It's called pedaling. And that can help prevent all of that concentration of heat and making it so painful. And of course, a nice warm, not hot, wash rag, and that put that on there with the pedaling can really help. They also say the first 24 hours after immunization, you can give Tylenol for fever, right? Is it normal? Absolutely. And some fevers are minor and some are 103. Normal. If it continues, is when they should go to their pediatrician. Which approach is best when administering an oral medication to a young child? As I said, sometimes it's an absolute fight to get some of these young kids to take their medicines. So they have said in research that a more direct approach is better. It's time for your medicine. So you want some juice or water with it? What would you like? Also, another way is, would you like me to put it in a cup, a spoon? Would you like to chew a pill? Or you like liquid? Put them a part of it, but it sort of makes them ready to take it. They're sort of admitting, okay, I'll take it if you give me it in a cup, or I'll take it if you give me it in a syringe, I'll squirt it. So that's how you would do it. I mean, and it can be difficult. Another thing, giving medications to kids and they don't want to swallow it, if you take a deep breath and quickly in their face, they jump and they swallow. And that's also another way if you can get it in their mouth. The nurse observes a 2-month-old infant actively feeding with a propped formula bottle. What facts should the nurse consider? I mean, the first fact I want to know, who did that, right? Who propped that bottle of formula on that 2-month-old? We know they're going to choke, and if a mother has done it, we need to again educate, let her know that we shouldn't be doing it that way. But not just don't do that, but the reason why that your child could choke, and we don't want those things to happen. 6 hours into a 24-hour urine specimen, the child is incontinent. What instruction should be provided to the parents? So if you have a 24-hour urine, they're usually looking for what substance is in there over a 24-hour period of time. If you lose a specimen, you have to restart it over again. Sometimes it's hard, especially on younger children, to get 24 hours of a urine specimen because of that, middle of the night, or forget, children get up and, they don't do what they need to do. So again, 24-hour urine specimens must be the entire 24 hours. Which procedure could be performed to obtain spinal fluid for an examination? Why we do spinal fluid? What examination are we looking for? Well, that's meningitis. What do you see with meningitis? Not that headache, the neck stiffness, high fevers, sometimes little rashes. And the way to rule it out is to do a lumbar puncture. That is done at all age children. Children's turned on their side, knees to chest on infants, and you hold them tightly. And the physician, in sterile procedure, inserts a needle into about the L4, L5 area, and they get a little bit of spinal fluid. I'm telling you, if the spinal fluid comes out clear, it's probably a viral meningitis. And if it comes out white and cloudy, that's showing you white blood cells, that's your bacterial, and that's your more serious of both of them. Thoracentesis is when you go into the chest looking for fluid in the chest cavity. Usually, sometimes the lungs will fill up, and that's when they would do that one. What is the most effective position for the nurse to place a toddler into administering medication? So they're sort of sitting there up a little bit. You don't want them down. They don't have to be, they want it somewhere where it will roll into the back of the throat easier and it swallows easier. If they're sitting up, standing, it could be spitting out, right? So that semi-Fowler sitting up a little bit and then giving them slowly. They don't have to drink the whole thing at once. Trying to catch up on you, Takia. What is the most significant reason for obtaining an accurate weight on a child in the hospital? Why is the biggest reason? Well, when you're admitted to the hospital, you need usually to give medications of some sort, and you need to give accurate doses. So we do that on going into a hospital. It's all about the medications we need to give. Now, why do we do it for a doctor's office? It's because we're making sure, are they gaining weight and height the way they should? And if they're not, we need to look at, is it nutrition or is it an endocrine disorder that's going on that we need to investigate further? Okay, so in the hospital, it's for your medicines. Absolutely number one reason. Let's see how we did today. Sibby, number 3. Good job. Takia, she beat you out. My goodness. You were there to the end. And Charlotte, good job. Number 4, KK and Candy, good job. So, I do these Kahoots. I try to give you all the information you need. I also try to get it to the point where you're going to see concepts on exams, make you think about it, and that's why I take time doing Kahoots, explaining Kahoots, and let you understand them. Any questions with anything about those Kahoots? I've sent you all of them for your exam 3. I wanted to go over about APA. Many of you, not all of you, but many of you have a hard time figuring out what is this about APA and how do I write it easily. All right, give me a second. Let me pull it up. So all I did is I went into a Google search bar and I'm like citing in the body of the paragraph APA. That's all I did. So it was just a random search. And then when I got there, this is what I found. Now, this happens to be a really great site. Owl, Purdue is a good one, and it shows you good things. And it's showing you different ways of citing. Now, you have a book, Leifer, Leifer, 2023. So they're showing you how to do if you have a bunch of authors. The RN book has 3 authors. All we have to do is put the first name at L and the date the book was copyrighted. That's where the date comes from, where it was copyrighted. And you could see sometimes there are similar authors, and you want to give credit. That's all it does. It gives credit to the author. And now you're like, where are you going to put these things? Well, when you were doing your paragraph and all of a sudden you wrote something information. So if we look at, we could do it a couple different ways. We could do it in the middle, we could do it at the end, or we can just say, according to whatever Leifer, and then you put in parentheses 2023, and that would be your insight text. So when you're doing them and you have a author, make sure you use the first name, comma, and then you're going to put the date, and usually you can see that the research is there. Now, what if you pull up something like the CDC, something that doesn't have a date? Well, there's something you could do there. Just put a comma, N period, D period, no date, because there is no date. It's just current off the internet. Another thing I saw was students doing a couple of quotations. Now, when you do quotations, you have to put in the page number it came from, like this right here, page 102, to show me where it came. Or if you don't have a page, paragraph number 3, which would be PP3. Okay? So it is easy. Just go back and put them in there, and that will get your papers from an 18 and it will go up to a 20. Now, we still have some time in class. What would you like to do? Do you want to go over math? You tell me. You guys are all half asleep today. You look exhausted. What can I do to help you? You want to go over another exam review? So it's math.
What's your email? Because I think I emailed the wrong email address because I never got a response.
bbogart@fortiscollege.edu. So the question is, do you want to do some review on math, or would you like to just to do an exam review at this time?
Exam review is fine for me.
Exam review.
Anybody else?
Exam review.
Okay, I could do that. Let me pull it up. Give me 1 second. Give me a second.
Are there exam reviews for all exams or just this one?
No, you have exam reviews every single exam.
Okay.
So I usually will post them. You will see they'll be posted usually the Friday or Saturday before the exam so that you can see what the exam reviews are. Also, putting in the times when the professors are doing them. You know, we still have one more that is tomorrow morning at 10 a.m. that you can go to, okay? And that was with Professor Luminoso. So if you want, you can go there. All right. Here we go. So, I mean, there's 19 slides. It's not crazy. I'm going to go over some of the really important stuff on you that you're going to be seeing, you know, and this can help. You know, my goal is I want everybody to get through this course. I want everybody to pass. So you need to tell me, what do you need for me to help you? All right. I can't guess everything. So I try, but I can't. Now, you have been given a blank, fill in the blank type of paper, as I said. Go back and go to your PowerPoint, go to the paper, and then figure out which is which, okay? That's going to help you with some of these because you have some of these as some of your answers on your exam, okay? So cephalocaudal, remember, it's head, cephalic. And then caudal is toe. That means you lift your head and then you walk by functional some steps about 1 year old, cephalocaudal. Proximal distal. Proximal is close. It's here. And then all of a sudden, the children, as infants, start with things here and then they work out into the periphery. And that's what that means. When we're doing maturation, it's how you grow and it's dictated by your inheritance. Who are you growing up with? Who is your mom? Who is your dad? Growth is just getting bigger, in which we know most children should get bigger every visit we see them. Development, it's, you know, it's how we start with just lifting our head to walking by the end of first year. It's that progressive increase in body function. You know, hereditary, again, it's maturation. It's the same thing as I said. Nuclear type of family. That is one mom, one dad, and they both have children together, and there's not stepchildren involved. Extended family is all the other people that are in your lives. Grandma, grandpa, parents, children, relatives, all of those. Now, blended, the family I have, is I have a boy and a girl. My husband has 3 girls, and together we have 5. We're blended. Alternative is things, it's like what we call a communal family. This is like your church family. This is like, I know I live in South Florida, and I've seen it a lot where there are migrant workers who come and they all stay together, like usually in one big house or 2 houses together or one complex. And that is their, what we call that communal family. They talk to each other, eat together, holiday together, et cetera, et cetera. Extrusion reflex. You know, ever take an infant the first time and give them a spoon to try to eat something and they stick it out? Well, that is what extrusion means. It's part of them trying to learn. They've sucked, swallowed, and breathed for 6 months. Now you're feeding them food. They don't know what to do with it yet. So it's a part of it. Grasp, we start out with that reflex. Grasp, go to voluntary, getting that rattle. go to crude pincer, to fine pincer, and then we start doing more things, putting things out of boxes and making blocks of 2 by the age of 1. Prehension is like pincer. Same thing, thumb and finger, picking things up like little Cheerios off of a high chair, right? This parachute reflex. Ever take a kid over, turn them on their tummies and put them down on the floor into a crib? Their hands and their feet come up, read about that 9 months of age. Well, that is what we call a parachute reflex. They're protecting themselves, and it's something they do automatically. Well, now let's go into all the things in here that refer to those toddlers. Well, negativism. No, 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 mine, 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 me, me, me. That's a toddler. Negativism. They like ritualism. They like the same thing of time at the same thing, the same foods, the same routines, and they're happy. Parallel play. Now they can play next to another child, but don't touch mine. You play with your toys, I play with mine, and we're next to each other. Parallel play. And again, egocentrism. Me, me, mine, mine, I do, I want to, mine. And that's part of it. And then we know personality is all those things that make up what they behave like. Freud talked a little bit today with some of the questions. Oral is all about everything in their mouth, and that's how they soothe themselves. Anal is that bowel training, potty training. Phallic is girls like their mom, their dads, and boys like their moms. It's just understanding now the difference in sexes. Latency is all about same-sex peers and creating relationships. And then we get to the adults, and then we start talking about genital. That means that sexual exploration and what adolescents do. And that basically says what I just said. Piaget. This is, one of those and these weird words. And how do I remember things like this? Well, it starts out with, remember, this is thinking, and it's taking small things, building on that, so they understand more and more and more, okay? Object permanence, right, is part of it. So they understood that I saw that teddy bear, and I know they put it somewhere, but I know it's still here. That's object permanence. So they're starting to think cognitively. Pre-operational is more about that imagination. It's about taking a broom and making it into a horse and riding around, putting those arms out and flying around the room and making airplane noises. That's that. Now, concrete operational. It was like, I got sick because I went swimming in the rain. Taking something, well, this is why I got sick. Something they knew. Okay, they figured that out. That's concrete, okay? Concrete means it's sitting there. It's in cement. It means it's sitting there. They understood it. They see it. And now formal operations, as I said, is taking an adolescent. They can fight their way out of a paper bag. They can critically think 100 different ways to make mommy do what she wants them to do or he wants them to do. And we know adolescents do that. I know me as an adolescent did it, so I'm sure it's still going on. And again, that's that. Erickson, the most tested area on HESI, NCLEX, and exams, to let you know. So you need to understand what Erickson talks about. So remember, infants is trust versus mistrust. What does this mean? Well, I trust if I cry, I'm hungry, mom and dad's going to come get me. I'm wet, mom and dad's going to change me. Somebody's coming for me. And that mistrust is when they don't come. And that's for many different reasons. Maybe mom fell asleep, she's sick, she didn't hear you, but this would be continuous, not just one time. Toddlers, another thing that's tested on autonomy versus shame and doubt. Well, Autonomy, autonomous means all about me. I want to do. All right. Automatically, I want to do it. And they explore the world. Now, what happens in toddlers is mom and dad and grandma, whoever else, are always saying, be careful, don't do this. No, here, let me do it for you. And you don't give that toddler the chance to do it by themselves, or maybe fall and bump their head a little bit, so that they learn they can't do that. Okay. So I want to do autonomy, but somebody's holding me back or doing it for me. Then we're going to go into the industry versus inferiority. This is all about school age. So industry is like a building that you make. It's a task that you do really good, whether it is playing a piano, whether spelling, playing sports, something you're good at, you receive praise at, and you feel wonderful. Now, one of the things about industry, and they test it this way. Now, you never want to give a school-age child a task they cannot complete. You want to make it challenging, but they should be able to complete it. Like, you'll not give them a 500-piece, same-looking colored puzzle to do, because they're not going to do it. They're going to get frustrated, and you want them to feel good about themselves. You'll give them a 50-piece one that you build a picture with, right? And they're able to do it with a little bit of, figuring it out. That is industry. Well, inferiority is stuff they just can't do well. You have kids good at school, not good at sports, and vice versa. So industry, a task I do well, and you don't ever want to give them chores they can't do completely in the end, even there's a little bit of work to get there. And inferiority is they don't do everything. And then we talk about the adolescence, identity, body image, all about who am I? What am I? What am I going to be? So that goes into that one. Now, we talked a little bit about Maslow's today, didn't we? We talked about physiologic needs. This is food, shelter, toileting. It's your vital signs, things that you can look and see. And then it goes up to the top, esteem. Well, what would be an esteem? Well, that's like the school age industry. What do I do well and people remark about? I'm good at ballet. People tell me I have esteem. That's Maslow, okay? Now, Kohlberg, this is all about right and wrong. And there's a consequence for either right or from wrong, okay? So when they're young, they have no clue about it. And then all of a sudden they start to understand. And again, they want to do good because they want to get the good strokes. As we get to school age, these are the pleasers. As I said, school age children do not want to do bad. They don't want to be punished. They want to please. That's what Kohlberg says, okay? And let's look at the infant. Well, a neonate is the first 28 days of life. It's another term. So 28 days, 4 weeks is neonate, but the first year of life is their infancy, okay? We know that children double their weight at 6 months and they triple it by 1 year old. And if they're not where they should be, we need to do interventions to get them where they should. Now, the first 6 months of life, they gain 1 inch per month as part of their gaining weight. And they say they should be at least 29 inches by the first year. But remember, some people are really short, and maybe that goes on to their infant too. By 1 year old, they don't have to be walking, but they should be attempting to, standing up by themselves, maybe holding on and attempting walking. It's totally acceptable. The earliest a tooth should come in is about 6 or 7 months, and they should get 1 tooth per month. And again, not all kids get it, But as my kids were, at 15 months, they got 8, which again, that was normal. For the first 6 months of life, they should only have breast milk or iron fortified formula. At 6 months old, we can start introducing solid foods. They say 5 or 6 months. Now, what's the best food to start with? Rice cereal. Why? It's the less allergenic. You have less allergies from it. So it's usually where they start. You know, one of the things mothers get upset about is nurses telling them, well, why aren't you breastfeeding? You know it's better. Well, not everybody can breastfeed for many different reasons. So as long as they're getting iron fortified formula, you know, that's okay. And we don't need to be putting that parent down who's not breastfeeding. Not everybody can do it. Now, sometimes as you are introducing new foods, which is at 5 or 6 months, right? One food every 4 to 7 days. And sometimes parents make their own food. There are some things that we need to teach them. Number one, you should not add anything, no salt, no sugar, and no honey ever should be given to an infant under the age of 1. What you need to do, let's say you're cooking carrots, cook them till they're tender with as little water as possible. You don't want empty calories here, okay? And then you strain it, puree it, and you put it in an ice cube tray. And then you can take out 1 cube to eat at a time. Remember, 1 tablespoon per year of life is all they need in food. And always remember to give the food before you give milk at 6 months old. So infants, we know it's the trust that they cry, they coo, somebody comes for them. We want that. We know sensory development, thought processes, cognitive. This is all about Piaget. We know there are something called a lethargic infant. They're just quieter. They don't respond to the environment as well. I mean, as adults, we're all different too. Some people like all the drama and some people are just quiet in the corner, right? Well, you have infants like that too. Now, you do need to treat them a little differently. So no bright lights, don't let the lights go into their eyes like that. Move slow, easy, slow, gently talking, and then sit them up. Let them look at the world, you know, one of those little city chairs, right? This is what we would do for them.
Yeah,
Talking about,
Professor, if I may, hello,
sure,
Professor, if I may
sure.
ask something quickly. These lethargic children, are they sick children or just quiet children?
Just quiet. Just quiet.
Okay.
Their personality's quiet. No, they're
Just
not
quiet.
sick.
Okay. Okay,
You
I
know,
thought he's sick.
yeah, no, they're not. They're not.
Okay.
That's a very good question. No, they're just normal kids that are just quiet.
Okay, okay. Then second, another question again with regards to milk. Children should not drink milk until after 1 year or 2.
1 year
1 year.
whole milk. At
What do
1
you mean?
year,
Mhm.
whole milk. They need the fat. Remember, they need it for their brains up to minimum of 2 years old. They need fat for their brain. So not
So,
skim milk, whole milk. At 1 year, they can change to yes.
so they should start drinking milk from day 1 up to 1 year, but it should be whole milk.
When they're born, it's breast
Mhm.
milk and iron fortified formula for the
Mhm.
first
Mhm.
year of life. At the
Mhm.
age of 1 year old, you can
Mhm.
change it to whole milk, not
Okay,
before. Okay,
okay,
because they
okay,
need the nutrients. Okay, but at
okay,
1
okay,
year, they're eating now, so they're better.
okay,
Okay,
okay, thank you.
you're welcome. Remember, SIDS, we need to keep these infants on their back to sleep. And of course, parents are going to worry about the flat head. Well, we turn them over and do tummy time, right? And that's when they're awake and alert, really awake and really alert. And their heads are going to round out even with just that. Remember car seats. Okay, very important. So any child less than 2 years old should be rear facing in the center of the car and should be securely anchored with a harness and then a seat belt holding that chair into place. Okay. one of the things that most of us, we put it back behind the passenger seat, right? So we can see it, but the book says, and it is recommended, they go in the center. And it does make sense if you think about it. Many younger infants, their parents love slings to put them into. And
All right,
those
I'm leaving.
those slings are great, but they're cloth. Make sure that their mouths are not covered so that you don't stop them from breathing. Toddlers, again, keep them on that fat till 2. You know, toddlers ages 1 to 3, they quadruple their weight about 2.5 years. They tripled at 1 year. It took another 1.5 years to quadruple it. That's how slow it closes down. Their fine and gross motor skills are getting better and better and more refined. Their digestion is better. You know, infants we feed every 3-4 hours. Toddlers can have breakfast, lunch, and dinner with a snack. You know, they do very well doing that. Remember, toddlers, all about their self. I do, me do, mine, mine, mine. And remember, they have to overcome mom and dad and everybody else trying to do it for them and telling them no, 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 no. Toddlers are starting to speak more. They're able to communicate and they understand a lot more than they can even communicate. They become potty trained, you know, they are also into that separation anxiety. And that's your next discussion question. Protest, despair, and detachment. Remember, protest is you have to leave the toddler there, ages 1 to 3. These kids, parents have to work, other kids, other things to do. Sometimes they have to go. And the toddler's going to be upset and they're going to scream and yell and go bonkers. And that's protest. And then after a little bit of that, realizing mom is not coming back, they go into more of despair, which is more of like regressing. They might start sucking their finger. They might have, you know, an accident where they're potty trained. And then it goes to detachment, where they don't care if mommy's there. They don't pay them attention because of this separation anxiety. That's what it describes. Parents need to know that it's normal for toddlers to be all about no, no, me, me, mine, mine, and these temper tantrums. And they do have them. Remember, when a toddler is not doing something right, they need to be put, not punished, but we call it time out. 1 minute per year, and they need to know why they're going on timeout. Preschool, ages 3 to 6, getting ready to go to school. You know, they are their bodies, they're able to control, they're more graceful, they'll be separated from parents a lot easier, and they're communicating really well, and their attention span, they're able to sit and listen to a teacher now. Their gross motor and fine motor. Well, gross is get up, go, go, go movement. Fine motor, F, fingers, all about things they do with their hands, whether it's tying a bow, buttoning a button, or coloring writing, okay? Gross is movement, walking, hopping, skipping. Piaget is all about, again, the hands up and the flying of the planes and all that stuff. They're getting creative, magical thinking. They're trying to do things, that initiative that Erickson says. And then Kohlberg, again, is that right and wrong. Now they're starting to know the difference. And the other thing about Kohlberg is now they're aware that mommy don't feel good. She's on the couch. Let me give her my teddy bear. She might feel better. She'll make your, let me kiss it, the boo-boo, make you better, right? You're starting to understand those things. You know, play, so important. Playing with other children, very important. It has to do with communication, socialization, and it's that cooperative play where they're trying to reach a goal, build a house, you know, finish a game, somebody wins. Now, some of the things that are a concern are that sibling jealousy. You like Jimmy better than you like me. I know you do, part of it. And then, of course, any sort of finger thumb sucking. Usually the finger thumb sucking, we hope, will be gone by their age 6, because that's when they start losing their baby teeth, you know, and permanent teeth come in. So we don't want that to be an issue. And again, they're finding that they have private parts and they're starting to play with it in masturbation. And as I've said about that, don't tell the kid you smack his hand, what are you doing? That's bad. You just change the subject. Come on, let's go out here and let's do this now. And you don't mention it. It's normal. It's exploration. Remember, bedwetting in some kids is all the time. Those kids that never's bedwetting, like at least a year, no bedwetting, they start to bedwet, there could be a physiological reason why. Urinary tract infection, diabetes insipidus, could be a lot of different things. So it needs to be investigated. School-age children, ages 6 to 12. Now they're perfecting everything. They're more awake, alert. They're, of course, physicality. They're being able to control their bodies really well. And again, they're into that industry. They love to do things well and they love to be praised. And they have a horrible sense of inferiority when they can't do absolutely everything. Freud is all about same-sex peers and being able to work in groups together. Piaget is all about understanding, different, you take the same coins and put them in different shapes. They know it's the same amount of coins, whether it's in a tall glass, a short glass. If they pour the short glass into the tall glass or the tall glass and the short glass, it's the same amount. A younger kid will take the tall glass. It looks like more, right? Well, a school-age child knows it's the same amount. They understand that. That's part of concrete operation. They've seen it. They know it. Growth, again, is small, slow, but all of school age is a lot. But every year it's slower. They are starting to, again, those same-sex peers. Their language is expanding. They are using some words that aerodynamics is a word that my grandson's using at almost age 7. It's the aerodynamics of a this that does this. There's no relationship, but he just loves using that word. So they're using words and they don't really understand them, but you can correct them, but they're being creative. They know all about right and wrong and being fair, and they want to do right. They don't want to do bad things. They don't want to be punished. Team sports are good, but remember, team sports should be later in school age. They can't handle it, that losing or that, the bullying that can go on with it. So you have to be really careful with it. But remember, kids who are in things like ballet and tap and sports, and they do it well, again, that's the esteem. That's the high level of the Maslow's hierarchy, okay? Now, if you have a kid, you're a school nurse, you get a kid to you, and they're not focusing good. Well, don't think that the kid is not trying. Number one, it could be vision or hearing. And those are the first two things that should be looked at, okay? It could be that they don't hear or they don't see and they don't know, so they're not saying anything. Adolescence, again, this is where they're starting to grow. They're getting breast buds and, they're getting hair in places and voice and all that starting to change, right? They are going from kids to adults. Again, it's about the identity, like I said. And it's also part now, these kids like their buddies, their other adolescents more than their family. It's just part of getting them ready to move out and be on their own after school or going to college, etc. We know Freud's all about that exploration. Piaget, again, they are extremely logical. It's abstract reasoning. They don't have to see it before. Remember, school age is concrete. They have to have seen it. These adolescents, as I said, fight their way out of a paper bag and they can get out. Remember, the physical is part of that puberty, and it's usually 2 years after they get the menses. We know that adolescent years, they're growing, they're rapid physical changing, and it's really a hard time for them. Number one hazard kills many adolescents. Any age, it's going to be motor vehicles. And remember, it's also gun violence, because now they think they're old enough to touch the guns, and that can happen. So remember ADPI for assessment. You have to assess, plan, implement, evaluate, what's going on? What could it be? Let's make a plan. What am I going to do? Then you do the plan and you go back, did it work? Okay. Remember Denver 2, very important. It has nothing to do with IQ, all right? All it does is it just looks at their development of their personality, their fine motor, language, gross motor. And if they're not where they should be, it's going to tell you they need more evaluation and early interventions, okay? Has nothing to do with IQ. Timeouts, 1 minute per year. And the BSA, it's a proper dosaging. And sex education, they, as adolescents, they're asking nothing about your personal opinion. You can't say, well, you should be abstinent. You shouldn't do that. Well, they're asking information. So give them oral and written information. So some of the adaptations like we did today, remember, all of the medications are according to height, weight, BSA, whatever it's going to be. Remember the way that they accept that medication, the absorption, distribution, etc., is going to be different in every kid because they're younger and their bodies are mature, and they're going to have different reactions than you ever see in adults. IM injection is vastus lataris, outer thigh, and adolescence is the ventral gluteal, where you're going to give those deep IM medications. Be careful with IV fluids. You're very lucky today. You have IV pumps for everything you need. When I first started nursing, we didn't have IV pumps. So many times fluid went in. And think about 100 mLs on an infant who weighs 3 pounds. That will put them into overwhelming congestive heart failure. So really be careful with IV fluids. Remember pacifiers, I've seen many things written about them, but they're self-soothers. They are part of growth and development. And if there's times where, due to whether going to surgery or whether a medical condition, give them a pacifier. They need that as part of it. And remember, if you are doing output on a diaper, number 1 diaper weighs 30 grams. If you take one off of an infant and it weighs 60 grams, you subtract. That means 30 grams. That's 30 mLs of urine. And that's how you do output. So, and then you just know your dosage calc. There's nothing crazy on them. Okay. We've talked about tetracycline. It talked to the grain of the teeth. And then what's the leading cause of death in children? I mean, motor vehicle, whether they're in it, on it, or underneath it, okay? And then the adolescents, they're driving too. And then what is a latchkey kid? Well, they're alone. There's so many things that can happen in their houses, so they are more apt for injuries. And you just got your own review for your exam. So everybody, thank you. I expect great numbers, right? Anybody who doesn't understand anything, let me know. I'll work with you, okay? Have a great weekend, guys.
Thank you. You
You're
too.
welcome.